I think just to acknowledge that we've been able to cover a variety of different aspects, from the bridging the gap and that connection or that collaboration piece between a variety of different key stakeholders, whether that's the people, the clinicians, or the research side of things. And I think even to what MDI is doing at the moment, they've also acknowledged that over the years, and over the last number of years in particular, they've also been trying to bridge those gaps as well behind the scenes. But I think we've got one question over here, so we can start off and then we can continue on. If anybody else has questions, raise your hand and we can send a microphone over to you.
Hello, good afternoon, sorry. My name's Owen Curry. I just finding that as a patient of one of the hospitals that was mentioned, like there was mention of care plans. I've been 14 years diagnosed and I've never once met an occupational therapist or had a care plan given to me by my hospital. Even when I meet my neurologist every year, to one appointment, I get a registrar. Last year they didn't even know what my condition was. I don't get physio treatment. I absolutely get left behind by the system. And I'm just wondering, like, you say, like, I've never had a team meeting with any of my doctors or anything like that. So I just find that in the adult services, there's absolutely no help for us. And I was just wondering how the panel felt about that, coming from the adult side of it. Like, I have FSHD type 2, and sorry, I know Professor Hardman, and I only know of Professor Murphy, because Professor Hardman diagnosed me in 2011, and Professor Murphy looks after my mother. But I've been left basically with nothing for 2 years, 3 years, because I'm a registrar who doesn't even know what type of muscular dystrophy I have. They don't read files, they don't do nothing. And it's a basic squeeze test. And I know you guys are under pressure. My sister's an MRI specialist, but there needs to be more done for the adults that way. Beaumont that's where I go. They haven't been meeting the requirements of even a basic amount of care for I find in the adult services. I have to bring my 75-year-old parents with me to be heard. I just find it very hard going in each year, and you get your fingers squeezed and your arms pulled out, and they don't keep a record of any of your control or anything like that, and you meet a new doctor every year. I just find it very I'm more worried about kids that are coming up, because it becomes very impersonal. You just feel I feel like a guinea pig half the time, because you're explaining it to them. Like, I've been told I'm the professional going in. I'm a car salesman, I didn't do college, and I'm told I'm the professional going into my neurology appointments. I just find that very hard. And I'm sure I'm probably not the only one here. And I know it's a tough question kind of to throw up, but there needs to be more awareness around it. And even like just the way they talk to us. It's just, I just don't know how to get help out of Beaumont Hospital. That's been perfectly honest. And I'm just looking see if anyone on the panel here, because I know I'm just saying there's a way that people can stand up for patients, not just like myself, but for the whole community, because we need more representation. We need empathy. And to be talking to like people, not as, I find like I'm talked at, not talked to, and not listened to. I've been told physio is a waste of time.
Thank you.
So I don't know, like there is a question there, like, how do we get the help that we're looking for? Sorry, I know it's a mad one to throw in at the start. I'm not trying to be difficult, just, I got retired 7 years ago, and I'm in Beaumont more than I am in my own house. So.
No, and I fully appreciate that, and thank you for bringing it up. Happy for the panel to start speaking.
I'm happy to address that if you want. Yeah. So, first of all, I think thank you very much for your comment, and I think we're not doing our job if we're not able to take criticism. So I think your criticism is appropriate and well levied, and I apologise personally to you for the feeling that you've been abandoned. We went through quite a difficult period from the time that I met you first to now in terms of our ability to set up specialty services in the hospital in which I work. There are space problems, there are all sorts of infrastructural problems within the hospital in terms of our ability to develop these specialty services. The muscular dystrophy service at Beaumont is a little bit fragmented at the moment, so there are 2 clinics. So one in collaboration with Richard Costello, respiratory physician, and then one that my colleague Stella Lefter has now taken is running, and Stella was appointed just a few years ago. So Stella is trying to coordinate the services to improve the quality of care that we provide. But it's a difficult process because we need resources. The rehabilitation services within the hospital are poorly funded. It's across the board. I'm sure Sinead will agree with me on that. And the recognition of the need for subspecialisation, even in centres like Beaumont, is still a little bit limited. So these things take a long time to put in place. So my area with the motor neuron disease service that we set up, it took 21 years to get the HSE to actually fund that service. So we got fully funded just 2 years ago. And that was a lot of blood, sweat and tears that we put together. And we begged, stole and borrowed during that time to get appropriately trained people, physiotherapists, occupational therapists and other healthcare professionals. I have every confidence that Stella, who's now leading the ERN programme as well for neuromuscular disease, will improve the service that she's taken over and is providing. And in fact, Stella works very closely with Muscular Dystrophy Ireland, and one of the projects that she has submitted for support is actually on FSH. But I mean, I think that from a collective point of view, I apologise for the sense that you have of being abandoned. And these are works in progress. Sinead will, I'm sure, agree with me that trying to get the HSE to listen about building strong services in subspecialty areas are very difficult. We got some funding a few years ago for additional nurses, and I think Sinead managed to get additional funding for a specialist nurse, for example, that would really help to coordinate the sort of care that you need and help to really put together essentially a liaison person or manager who will liaise with the MDI. But trying to actually implement that, even when you get the funding, Sinead, trying to get the powers that be to actually spend the money where it's supposed to be spent is really difficult. And Sinead can talk about that as well, I think. I think it is going to move, and I think we have been successful in identifying somebody who will become the neuromuscular nurse specialist, and that'll help a lot, I think. But it's been a long and difficult course, and we're aware that people feel like they've been left abandoned while we're trying to develop and grow these services within the centres of excellence that we have. So apologise personally to you and collectively to you, and thank you for bringing it up, because these things, if we're not able to listen to people saying they feel abandoned, we're not doing our job. We have to be able to hear that.
And it's nothing you you don't have to apologise for the HSE. As I said, my sister works in Tala Hospital. I know you're strapped and the way things are, so I appreciate the apology and thank you very much. And it wasn't a dig, it's just I wanted to open it up because the transition, I didn't know as a kid. I just want to make sure, I have loads of cousins with kids and nephews. I just want to make sure that the service is there for the future for everyone. That's all. Thank you very much.
The MDI is planning to build some registers for neuromuscular disease. That's what Stella is doing as well. So the idea there would be that we wouldn't lose people. We'd know about families. We'd know who's coming up in the next generation as well. And it's I mean I think Sinead and I and Imran, we work in the health system, so we do take responsibility for services that don't work. Sometimes you're responsible, accountable, but not responsible. So we are aware of the problems, but actually the responsibility to fix the problems is outside of our remit, and that's really frustrating for people. Sinead is the clinical lead for neurology at the moment, and I'm sure that it's an incredibly stressful job because she can see what we need to do. But getting people to actually take responsibility for doing what we say needs to happen is really, really difficult. So, Sinead, do you want to?
Yeah, I mean, I think probably a lot of adults feel similarly to you, because I think particularly for neuromuscular disease, a lot of people are diagnosed in childhood and they have very good resources often, in the CRC, and very good access to physios, OTs, all of these things which are really important. And then when you turn 18 and you move to the adult service, it's entirely different because we don't have those services in the adult services. And we know that, and we know that we want it and we should have it for our patients. But the truth is that it's not resourced by the HSE, and I don't think they really understand the importance of it. And the other thing is, like I was saying, a lot of people with neuromuscular disease particularly travel a long distance to their hospital appointments, so they're not attending their local hospital. And if that's the case, things like physiotherapy, occupational therapy in the hospitals serve the catchment area of the hospital. So, if I see someone who's travelled to me from Donegal, my physio in the hospital can't see them. And, we ask the GP to refer them to the local community services, but they're also strapped and tight, and community services often offer a very, 6 sessions or something. It's not really a service that's designed for people that have a chronic neurological condition that needs really regular input from HSCPs. And I think, as neurologists and doctors who look after people with these conditions, we know that and we see it all the time. But as Orla says, have very little control over providing those things because they're not resourced. But I think that's where the MDI and people like that come in advocating for those services with the Minister for Health and Department of Health and everything, because that's a message, I think, that just needs to be repeated and heard.
But just on a note of not complete pessimism, there are 2 things I think that have happened that have given me a glimmer of hope. One is that the hospital systems were the health system during my professional life was always measured on trolley counts. It really irritated me because trolley counts are for acute things that people get. A lot of it has to do with poor services in the community. People go to the emergency room because they don't have to pay, and they see somebody and get all their treatments. They don't have to pay for the investigations, whereas they go to their GP, it's a big long waiting list. So trolley counts are a function of a dysfunctional primary care system. And so it's not a good reflection of how the health system works. It's a reflection of one part of the health system. There has been a move away from thinking about trolley counts to things like, outpatient lists. So Sinead's under pressure to look at outpatient lists on new versus return. So that's actually a good thing because it means that the HSE and the Department of Health are thinking a bit more about a wider perspective. And the other slightly positive thing is this idea of neurorehabilitation. So there is a movement towards building programs within the community to support people who have neurological disability. Now, there's a lot of, they're going to be under-resourced because, trauma, head trauma and stroke are a huge thing, and people with long-term neurologic disability or progressive neurologic disability might get a little bit squeezed out, but at least they're there. And at least, for example, the physiotherapist that works with Sinead can now lift the phone to the community rehabilitation services that's going to be up in Donegal and say, I have this family that really is going to need some integration. They need to know about, neurorehabilitation service needs to know about this family you need to put in. So it's nascent, it's not there yet. But I think with this group and NAI and us, I think we can try to drive that forward to say, look, we need equity of care. No matter where you live, you should be able to get the same level of care no matter what your disability is. You should be able to access the right services in the right place. And that's what Sláinte care is about as well. So I do think it's really, when you're in the thick of it or when you're at the receiving end, it looks like nothing is happening. But to me, the arc is wide, but it is tending towards improving services. There are lots of wobbles on the way. But compared to when I started out, it is a bit better than when I started out. And I'm hoping that with people like Sinead and other people who are driving this forward, that it will continue to improve over time.
And I think just to that point as well, while unfortunately your situation is probably not the only isolated case of it, there's probably other people that are facing that too. And not to say that that's acceptable, but I think just to the panel's point as well, this is also what MDI can help with. And even for the patient registry that they're going to be setting up over the next year or two as well, it's having identified people within that to help reduce people falling through the gaps that we talked about earlier, but also providing this as data points and robust measurements to say, we have this many people with FSHD or with DMD or DM1, DM2, whatever the case may be, so that we can provide empirical evidence to say, hey, Jesse, these are the resources that we have gaps in that we don't have. They need dietitians, they need occupational therapists, they need physiotherapists as well. So by having this and by getting people in Ireland, because there are other ones that people in Ireland are able to be eligible to register to as well for the European Research Network and others as well. They're hugely beneficial, but by Ireland and with MDI having their own one, so you talked about getting the funding to do that is not trivial. MDI has secured that. So by building all of these things together, well, it's going to take time to get set up. in 5 years' time, we could be in a much stronger position to say, we need, better centres of excellence that have more equipped people and with the right people in there to serve the community that we have as well. Yeah, I think we're just running a little bit over time, but I think we have a little bit of time to squeeze in some more questions. So if anybody else would like to raise any questions or make any comments to the panel, happy to take them. Do you have some there? No?
I might just ask a quick question. As we know, there's a lot of emerging drug-modifying therapies, disease-modifying therapies and gene therapies. And we also are very mindful that the reimbursement process in Ireland takes a long time. I guess I'm just wondering, do you have confidence that Ireland will be able to keep up with the advances that are happening in this space by being able to provide these therapies?
Yeah, I don't know. There are massive advances and have been in the last number of years. Even, in the one disease that I talked about, there are now 4 or 5 different gene therapies that are available that, improve outcomes. And that's really great, but they are highly expensive drugs. You're talking hundreds of thousands of euro a year per patient. And that's the reality of genetic therapies for all of these rare neurological and neuromuscular diseases. And I've no idea. Obviously, that the coffers are not infinite. But I suppose, if you improve outcomes and you get people on treatment early and diagnose people early and they have better outcomes, then, they can contribute to tax returns and, have less disability, less hospitalization. So you are, in some ways, it's not all putting cost out. Do you know what I mean? You are making savings by treating people with these conditions. But, it's potentially a very big problem and a concern. But so far, if the companies can prove with the trials that they have, that they provide good outcomes, that there are benefits to patients and all of these things, then, they are reviewed by the NCPE and are reimbursed if appropriate. And I don't know, I don't know how...
Yeah, I agree with Sinead. I think this is a problem. It's not just an Irish problem. This is a problem across the world. And actually, to be fair, it's a first world problem, because I was at a meeting last week with the Alliance for Motor Neuron Disease, and we were talking about this. And there are parts of the world that can't even get really basic care. So this is, I think we are in a first world, so it is true, but it is a first world problem. And the first tranche of treatments are always going to be very expensive. So I think Sinead is right that the metric by which we measure outcome may require some adjustment. The measurement around things like QALYs and how we determine whether a treatment is beneficial or not. Do we do it with survival? Do we do it with activities of daily living? So those things need to be fixed a little bit. EMA is very interested in this, actually. It's very interested in real world data, and it's very interested in the impact of a treatment on the real world experience of people. So we've been doing some work with EMA around that sort of thing as well, about, and with industry partners as well. How do you measure the real world impact of something if you don't know anything about the real world impact of the disease in the first place? So that's the second thing. The third thing is that in Ireland we have a problem which could be a problem or not a problem depending on how you look at it. So we have a national health system, as we know, which is mostly funded in the secondary care system and not the primary care system. So the health, the national pharmacoeconomic assessment determines whether something is value for money, but it's not legally binding. It's not like in the UK where NICE is legally binding. So Michael Barry, who runs that program, National Centre for Pharmacoeconomics, will make an assessment. It's usually negative, actually, but and then that'll go up to further up in the HSE. And there's a huge drag there within the HSE, because one of the modifiable costs is actually drugs. There are very few costs within the HSE that they can actually control completely, and drug budgets is one of them. So even if a drug gets past the National Centre for Pharmacoeconomics, and even with a tendency towards positive, it goes up to this black box within the HSE that determines yay or nay. And it's not just for neurological drugs, it's true for cancer drugs, it's true for most drugs. So that model is and it can become quite political at that point then. So I don't know what the answer is other than what Sinead was saying. It's going to be a problem no matter what, because these drugs are going to be very expensive. Do you treat if we produce more drugs for people? Does that mean we do less hip operations? As Sinead said, there's a finite budget, and nobody has fixed this problem. This problem is the same. I don't know if Reagan might want to comment on this, because in the US, stuff gets approved really quickly, but the FDA doesn't have to take responsibility for the reimbursement, and the reimbursement issues in the US happen with insurance companies, and so there's a huge variability. And if you don't have a job and you're under insurance, you're screwed in the US. You may want to refute that, Reagan. But
No, it's complicated across the globe. I think actually some of my colleagues who've had figured out a solution are those colleagues of mine in India who've told the companies that they have huge patient numbers, but they will only allow the company to come if they'll also provide BiPAP and cough assist. So making sure there's kind of a bartering going on, but we have a huge problem. You're right. It's just difficult to access because of the insurance issue as well. So, but I think we need to tell the biopharma companies that they also need to take on some of this problem themselves because it becomes an ethical issue, right?
Even more and more, there's a lot of new drugs that are coming into different stages of clinical trials. So I think over the next 10 years, this is probably going to be one of the bigger bottlenecks that we are going to continuously see in terms of being able to get access and to have them in Ireland. And I think case in point, we're already seeing that with some of the SMA drugs for being approved, and also for Duchenne as well, for Givinostat. So this is probably going to be the start of bigger pieces with that as well.
The SMA story is actually a particularly awful story. You're probably aware of this as well. So the SMA story is that if you were 18, or if you were under 18 on the day that the drug got reimbursed, you got Spinraza at the time, or risdiplam afterwards. If you were a day over your 18th birthday and you had the exact same disability or less, you didn't get the drug, and that is still the case. There's about 35 or 40 people in Ireland with who were over 18 on the day that the reimbursement was permitted, who still are not able to get any kind of disease-modifying therapy. Now, we're doing a little workaround on that at the moment, because there's a new clinical trial coming in for SMA, which we're going to try and get everybody who isn't able to access any of the disease-modifying therapies. But we've been in with Michael Barry and with the Department of Health saying, look, this is fundamentally unfair. This is a human rights issue. We've been at the AV room in the Dáil about this, and we were pushed back. So Michael Barry put in a full pharmacoeconomic assessment. Again, the company has to do this for 10 or 15 patients. They're not going to do it. So that's fundamentally unfair. And that is a case where actually we should be pushing really hard. And there could be a political decision, but I don't think this minister is a woman for turning on this, actually.
Mm-hmm. Yeah. Yeah.
A question about expert-led information. How can clinicians or organisations better support patients and families in identifying reliable expert-led information? And from my own personal point of view, there's work that could happen on the psychological contracts that the patient enters into with their clinician on day one. I think if patients, I'm a family support with MDI, if patients understood from the off what the reasonable, practical, everyday expectations could be of almost everything, including sources of information and medications, I think we'd all be able to work together. I think that psychological contract is really important, But the question is about expert-led information, because of when you Google, Does that make sense?
Yeah. There's a huge amount of misinformation on the web, obviously, and yet there's a lot of very important and useful information, and knowing which is which can be challenging. Increasingly, I am giving patients in clinic suggestions as to which websites to look for. depends on the condition. Some conditions they have, there's very nice information which is very reliable, very extensive, very patient friendly, and then for other conditions that is lacking. But yeah, I mean, increasingly I'm giving people websites in clinic and saying this is the one to look at. Don't just Google it.
There's a huge amount of psychological stress caused by waiting, misunderstanding, not knowing, reading the worst case scenario on the first week or two, and then trying to work your way back from there.
I think engagement with the voluntary organisations such as MDI is hugely valuable, and the MDA in the US as well provide proper evidence-based support. And I think there's a move towards these sort of webinars now, where recordings of experts providing information about particular conditions and toolkits for clinicians as well. So I've been involved in some of those as well, about how you engage, how you break news, and how you support, how you build a care plan. I think they're very important, and I think the voluntary organisation is a very important partner in providing that and linking the sort of work that we do with the real world experience person through the MDI or the other voluntary organisations.
I think the other another source of really bad misinformation is AI now.
Yeah.
So a lot of patients come into clinic using ChatGPT, searching their condition, and the information is invariably incorrect. So I most commonly advise not to use that, and similar to what Sinead said, provide factual websites through MDI or through the NHS have good patient information sites as well, as do in the States.
The HSE has a program as well. It's fairly basic.
Yeah, it's
but
very basic.
That,
So HSE, My Health Matters, is it, or my?
Yeah.
Anyway, there is a lot of information, but it's generally very basic.
very generic.
Yeah,
generic,
it's like I have tingling. It's
Yeah,
it's not what is the treatment for Duchenne's. Do you know what I mean? Yeah.
I think, relating to the earlier question about the FSH, the sense of belonging, the sense of being part of a wider group, and membership of an organisation like MDI is really important. That sort of peer support that we provide. I can see Reagan nodding her head as well. And you showed that really well, Reagan, with that patient scientific meetings that you have where people feel like they're part of a group and belong and can provide a lot of peer support as well. I think peer support is really important as well, actually. People who have walked the walk have had the same journey and can help to support people who are just beginning on their journey. And that's what Reagan described, I think, in your presentation.
Yeah. 100%, and it's so essential that you don't feel alone. And years ago, I would try to exchange people's phone numbers. If people are shy, put them in the same room together, they'll start talking, or having these forums like MDI has or different organizations. Then you recognize someone with your same condition has navigated that road maybe 5 or 10 years ahead of you, and you see what's possible. It's absolutely invaluable. It's a huge factor for quality of life. We
have in the motor neuron disease clinic in Beaumont, we're better than we used to, but we used to have 3 or 4 hour waits for people. They'd be giving out, but people would actually get to know each other and exchange phone numbers that way, and then they have a carers weekend that happens. It happens in the polio clinic as well, the polio clinic that we run, which is the first Thursday of the month. It's just like a reunion of all the people with polio, and they all know each other. and they do a lot of peer support that way as well.
Are there any other questions or comments from people? No. Dymphna, how are we doing for time? Okay. So I think I've just got a few questions for the panel as well. So we've talked a little bit on the clinical trial side of things, maybe a little bit on the diagnostic odyssey side of things in some capacities as well. But what do you think over the next couple of years that you're thinking are going to be most impactful for the community from MDI for bridging these gaps, for which we acknowledge that there are many, but would be most beneficial?
From MDI in specific, I mean, I think a register of patients is really important. And like you've heard from Orla, Ireland is an ideal location really, because we're circumscribed in some way. But having a register is really important to improve things for everyone, particularly when you're looking for resources, being able to say there are this many thousand people with you know, a neuromuscular condition that don't have access to, you know, there's only 4 neuromuscular clinics. Like that would be really invaluable, I think.
Yeah. I think even I'd love to get your thoughts on it in terms of we have that so we can identify the different people within the different types of muscular dystrophy. And again, within each group, there could be multiple different genetic compositions within that as well. But even trying to get you testified on the baseline understanding of people's condition as well to see how that progresses over time. Do you think that that would be helpful in terms of longitudinal studies or natural history studies as well?
Yeah, so natural history studies are really important because, as you've heard, when you go to trials, you need to know what the natural history of that disease is. So, I mean, that is something that is, you know, a registry is not a natural history study. You can collect longitudinal data, but it's not the same thing as a natural history study. But there are natural history studies in a number of diseases happening already. And that's really important for individual diseases if you're coming along with a drug, for sure.
And in terms of go ahead.
No, I think a register is a really good infrastructure from which to start, and then a natural history study would be a nested study within the register. But I think there's a huge amount of additional information that you can add to the register. There are common data elements within the register, so Sinead is right. Depending on the complexity of what you want to collect. But for our register, we can do natural history studies with our register because we have all of the key elements, but then we do nested studies which do deep dives into some of the aspects that we want to look at. To answer your question, I think 2 to 3 years is a bit short. I think if you can develop the infrastructure that will allow a proper register to start, and you get through all the issues about the legal and governance and framework and some kind of funding structure to allow the register to grow and develop. Because registers, it's in the paper, the first 3 years of register, the data are so disparate and not really discoverable in the sense of using them for meaningful analyses. You really have to register for about 5 years, and you can't discard the first couple of years of data if you want to use it for analytic purposes. So I think, you know, if I were to start, where would I start? I would start from here, and I'd put the resourcing into really supporting the register. I would also take on board the comments that we've had around, you know, people feeling left out and neglected, and the psychological contract not really being addressed. So educating us, you guys educating us about how you do this properly, and making sure that, you know, we're part of as Reagan was saying, you know, it's a whole ecosystem, and we're part of that ecosystem. And the third thing then I think is engagement with Europe, and Sinead is talking about that, the ERN. There's lots of problems with the ERN as well, I'm sure you'll agree, Sinead, they've no money for one thing. But, you know, being part of the European network for all of these conditions is really important, so that all of those things will allow us to bring in clinical trials in the future.
Absolutely. And I think hopefully at the conference this time next year, we'll be in a very good shape for launching the patient registry within Ireland that MDI is having as their initiative as well. So I think it'll be a very interesting conversation, a productive conversation, and seeing how that grows over the next few years as well. But I think we're just at time now for the end of this workshop. So we will close it there and say thank you very much to all of our panelists and for everybody engaging in the conversation.